Hello and welcome to the second annual ENIGMA IPV and Pink Concussions IPV Brain Injury Conference, Breaking Down Barriers and Building Understanding. My name is Carrie Esopenko, and I'm an associate professor at Icahn School of Medicine at Sinai in New York City. I lead the ENIGMA IPV working group, which seeks to support and expand global research on IPV-related brain injury. ENIGMA IPV, in collaboration with Catherine Snedeker from Pink Concussions, co-developed this conference with immense help from our conference organizing committee. So last year, we set out to provide a free and easily accessible venue to provide research and practice-based information to partners on IPV-related brain injury. Last year, we saw just under 500 people register, with many also viewing the recorded sessions online after the conference ended. This year, we are excited to build on that momentum with more than 700 people registered for this conference. I am in a state of shock over the number of people that were as excited to be here today as we are, and so thank you for registering. Again, this year, we are excited to see a broad I'm going to get to the next slide. A broad representation of registrants globally, as well as registrations from many community, advocate, and provider roles. We also heard the feedback from you last year and sought to include more diverse representation in topic areas and really expand the knowledge on this important public health concern affecting 1 in 3 women over the age of 15 globally, and having a particularly devastating impact on women of color, women with disabilities, Indigenous individuals, and gender and sexual minorities who are at the highest risk for IPV. We have all been using our voices to sound the alarm on the effects of IPV-related brain injury. Even though there are many gaps that we need to fill, we are thrilled to see the increase in awareness and research being done on this topic and the increased focus on providing care for IPV-related brain injuries. Over the next 2 days, we hope to bring further awareness and understanding of IPV-related brain injuries and offer hope for the future as we begin to break down the global barriers and surrounding research and treatment of IPV-related brain injuries. We have an incredible speakers here today, and we're excited for you all to listen and hear the incredible research and practice-based work that they are doing. And it's going to be an incredible 2 days. And for those of you who have to come and go as you please, we will have the sessions recorded and you'll be able to check them out later. We'd also like you to, if you can, do our pre-conference survey. The survey really does help us understand where you're coming from, what you want to see, and how we can improve on this in the future. So if you can scan this and fill it out, we would be eternally grateful. Ella also sent out an email with the link to the pre-conference survey. And at the end of the survey, or at the end of the conference, we will also be sending out post-conference surveys so that you can provide us with what you liked and what you didn't like, or how we can improve next year. I also want to immensely thank and acknowledge and share my gratitude to the conference organizing committee. These individuals worked tirelessly to develop a program that we hope address the suggestions from last year's attendees and advances our mission of providing a thorough overview of the current research and practice-based information on IPV-related brain injury. As a committee, we would also like to share our statement on diversity, equity, and inclusion. We, as a group, are committed to diversity, equity, inclusion, regardless of age, race, ethnicity, sex, gender, sexual orientation, religion, geographic area, socioeconomic status, disability status, and equity-deserving identities. As a committee, we are cognizant of the biases that exist in clinical practice and research, and thus have endeavored to increase inclusivity by including diverse speakers, a range of understudied topics and work that incorporates underserved communities. We have worked to increase accessibility of the conference by providing a free virtual and recorded environment. And we hope that this is one small step towards positive change needed in breaking down barriers and building understanding. We would also like to acknowledge that our work spans many First Nations, Inuit, and other Indigenous territories. Moving forward in a way that promotes anti-racism and inclusivity, we are committed to educating ourselves and understanding the truth of our shared history with Indigenous peoples. Sorry, slides got out of whack here. We also want to provide a content warning. Given the prevalence of IPV, and we know why everybody is here today, but given the prevalence of IPV, we recognize that the content of this presentation and related discussions may be triggering for some attendees. If you would like support during or after this presentation, please reach out to the conference organizers through the chat and we will provide you with support. Please also feel free to log off from the Zoom and rejoin later, or if you would like to mute any of the sessions, please feel free as needed. So some housekeeping before we get started. You will see a question and answer box. Please provide your questions that you have for any of our speakers in that box. We will then make sure that they are addressed to the panelists or to the speakers. We also have, given that so many people registered to this, we do also, as you saw in the email, have to give a heads up that we only have room for 500 people in the webinar at once. So if we hit the max of 500 at one time, attendees may be in the waiting room until someone exits. However, given the global scope and that many people will have to be viewing this as a recorded sessions, we don't anticipate this being a problem. But if you get stuck in the waiting room, we are full, which is exciting, but also I apologize for that. But again, we'll hope that you can join at a later time. So with that, let's get things started. First up, we have our practice-based keynote presented by Hannah Varto titled Embracing and Creating Non-Acute Medical Forensic Services, a Healthcare Response to Violence. Hannah is a nurse practitioner who has been practicing in the field of forensic healthcare for almost 22 years. She established Canada's first outpatient subacute specialty forensic clinic in 2015 in Surrey, BC. She provides non-urgent medical forensic care to survivors of recent interpersonal violence. Hannah recognized the misdiagnosis, assessment, and treatment of non-fatal strangulation in her patient population, and as such, in 2021, established a strangulation clinic that focuses on this specific aspect of violence. Sorry, Hannah realized that she was sitting on a wealth of data about survivors of violence, including incident details and injury characteristics. She teamed up with a group of UBC researchers to begin looking at blood biomarkers after brain injury in her population. She has taken part and led a few studies examining program data for trends and correlations associated with interpersonal violence. Hannah is a contracted instructor with BCIT's Forensic Health Services and provides legal nurse consulting. With her recent completion of myoactivation training to treat chronic pain, Hannah looks forward to integrating this treatment into her practice and exploring its application to her patient population. And with that, I'm excited to welcome Hannah Varto.
Carrie, do you want me to turn my video on now?
Please.
Okay. Hello, good morning, everybody. I'm going to work on sharing my screen. I can see my hair is on. I'd like to also introduce Levi in the background here. He is our therapy dog at our clinic, and he'll be, I think, sitting in today, likely falling asleep. I'm going to share my screen here and turn presenter on. There we go. All right. It's an early morning here in British Columbia. It's a very rainy morning in British Columbia as well. Um, it's just past 7 a.m., but I'm really super excited to be here. I attended last year's conference, and I went back and actually re-listened to some of the webinars afterwards, just to glean that extra information. And so that's really exciting. So thank you for having me here today. I think Carrie did a good intro, so I'm going to get started, and we're going to talk a little bit about the development. Oh, did somebody
Yeah,
say?
sorry, it's me interrupting you already. I'm sorry, but we can't see your slides.
Oh, of course. Why not? Oh, how about this? We'll try that. How's that?
Perfect. Thank you so much.
Awesome. Thanks, Carrie. All right. So we're going to talk today a little bit about how I created, with a lot of support. So I'm not by any means, I'm not the only one who did this, but helped to lead the creation of a clinic, which we call Embrace Clinic. Therefore, the name Embracing and creating non-medical or non-acute medical forensic services here. So first, I'm not sure who has the poll questions, but I had a little poll for people. I wanted to ask, how do people access medical care after they have a forensic visit? So if they go to the emergency department or a specific place, it should be popping up on your screen. Select all that apply within your community. And if you're not a clinician, that's okay. Take a guess. Where do you think people are accessing care after they've had a forensic exam? And when I say forensic exam, some people, lay people might call that a rape kit. Don't love that term. And it also doesn't apply to people who have domestic violence experiences or sex or exploitation only. And so we call it a forensic exam for the most part. So if you just click on there, please just, I want to get sort of a sense of in your own communities where you know or think people are accessing follow-up medical care. And I'm thinking of things like follow-up STI screening, management of concussion or head injury, management of neck injuries or from back and muscle strain, maybe from struggle, or maybe suture removal. How are we doing with that poll?
It is up. Do you see it?
Okay. I don't see the results. I see the
Okay.
poll, but I don't see the results.
So, hi, this is Sophia. So we have 73% of the people have responded. So there's still about 40 people who are still responding.
Mhm.
I can, if I'll share and see if I can send you a screenshot, or I can read out the results if you like percentages. Let me know.
I think you can show them. There may be people here who don't know at all, and that's okay. And that's part of the point as well, is that a lot of people don't know where we go afterwards.
Sounds good. So I might have to steal your share screen for a second just to
Go ahead.
show a quick
Yep.
image because it's a Zoom feature. I'm unable to share that. So let's. So hopefully everyone sees this quick screenshot.
Great. So it looks like most people said their family doctor, maybe a Planned Parenthood or sexual health clinic, maybe a walk-in clinic, and then they probably don't. And I'd say that that's a pretty good guess that they probably don't. I'm going to take my screen back now. Um, let's get back to my screen. There we go. I still have my poll up. Okay. I hope you can see my screen there. All right. So yes, So people might go to a family doctor if they have one. I don't think Canada is unique in that access to primary care can be quite difficult. I know Canada right now, very few people have access to a primary care provider, so a family doctor or a nurse practitioner. Can they get into this person even within a month? Are they comfortable with them? Does this family doctor also treat their husband? Do they also treat their parents, for example? Are they from the same culture? And so there's a lot of concerns that I hear from survivors of violence about why they don't want to inform their family doctor or primary care provider. Youth clinic. Youth clinics are great. They're very youth friendly, but you have to be under a certain age. Here in British Columbia, most of it's under age 22. And so where do people above that age go? Sexual health clinic, Planned Parenthood clinic, if there is one in your community. In British Columbia, they often have limited hours. So they're only open on Tuesdays and Thursdays from 2 to 4 p.m., for example, in some communities. So there's very limited hours. It's very sexual health focused, so a great place for sexual assault survivors to go. I'm not so sure how thorough the management of, say, a head injury or concussion is going to be in a sexual health clinic. So very sexual health specific. Walk-in clinics. Yes, we can go to a walk-in clinic and get some care. You've got 7 minutes to tell your story or to explain why you're there and the multitude of factors and issues that may have recently occurred. As we know, survivors of violence are not just one issue. It's not just a head injury. It's sleep concerns. It's emotional and mental health management. Sometimes it's triggers for substance use. Sometimes it's other issues like needing suture removal and STI screening and concussion management. That's not a 7-minute visit. And typically here, at least in Canada, they need to stand in line at 7 a.m. so that when the clinic opens at 9 a.m., they can actually get in, because often our walk-in clinics are full within the first hour of them being open and they're taking nobody for the rest of the day. So not super accessible, very, very limited time with somebody you don't know very well. And to be honest, most survivors don't access follow-up medical care. If they do, it's for very specific things like suture removal, for example, or they have dysuria, hurts to pee, and they're actually seeking something very specific for a symptom. They may or may not disclose the recent violence or the reason that they need to have this care. And so that's where we sit in most communities and places for people who've experienced recent violence. So the other question then is, where do people in your community go if they don't qualify for a forensic exam? So most forensic exams are done within 1 week, but let's say this incident happened 10 days ago and they're now finally like, my head has just been pounding and it hurts a lot. He punched me multiple times. Maybe I should go see someone, but it's day 10. And so it's too late for the forensic exam piece, the very focused, urgent, emergency department type care. Again, their options are, as we looked at in my previous slide, walk-in clinic, family doctor if they can get in, youth clinic may or may not look at their head injury, sexual health clinic, they're going to be focused on sexual health. So there's not a lot of options. Or if somebody says, I don't need a full forensic exam, I'm not going to involve police, I'm not ready for that, I just need some really focused care for my current symptoms. Well, emergency department might be a good place to go, but in many cases, these aren't emergency department level needs. So, being hit in the head, maybe you want to go get checked out, but you're going to need some follow-up care for managing that concussion, for example. But it hurts to pee. That's a walk-in clinic visit. That's an urgent care visit. That's a visit to your family doctor, if you can get in. But maybe they want more thorough care, and I argue that they deserve more thorough, comprehensive care specific to their recent violence, not just about, oh, I'm sorry, it hurts to pee now. So I'm going to introduce you to our services here in British Columbia in the Lower Mainland. I work in a community called Surrey, British Columbia. It is the fastest growing city in British Columbia and probably one of the top 3 in Canada. A large immigrant population, a lot of gang activity in our community, a lot of homelessness. We are about a half-hour to 45-minute drive from Vancouver, depending on the day and the traffic. Many people will know about Vancouver's downtown east side, which is a highly populated area of people who are very vulnerable, substance using, precarious housing, homelessness, etc. And it's very concentrated in an area in Vancouver. A lot of resources exist in that area, and a lot of focus and a lot of attention is provided to that area. However, in Surrey, we have just as many people and a lot less resources and a lot less focus. And so we have our own set of issues here in British Columbia and in Surrey. The organization that I work for is called Fraser Health. That is a health authority. So in British Columbia, each region is divided into a health authority, and that is the organization that runs our hospitals and our public health systems, and some, I guess, some long-term care. They don't run primarily a lot of primary care, although they have a handful of primary care clinics, often for marginalized and more vulnerable people who are turned away by traditional family physicians working on a fee-for-service model. And so the health authorities will run some urgent care and primary care clinics with that focus. So in 1992, an amazing emergency department nurse, her name was Sheila Early, she was working in the Surrey Memorial Hospital Emergency Department, one of the busiest emergency departments in Canada, and she saw somebody who had come in after a sexual assault, and her and a physician muddled their way through a rape kit that was this box from the police, and they sort of were reading the fine print and really sort of desperately trying to do right by this person. She quickly realized, we can do better. And this can be nursing. This doesn't need to be a physician-focused service. And she developed one of the first 2 sexual assault nurse examiner programs in Canada. And she was the first nurse in British Columbia to perform a sexual assault nurse exam, a forensic exam. And so she started the program with a lot of support and have muddled through it. Since then, things have definitely grown and snowballed. And in the mid-2000s, the program changed its name to Forensic Nursing Service and began seeing survivors of domestic violence and trafficking. A few years later, we also integrated child maltreatment for ages 2 and up. And so this was an amazing program. And I'm going to tell you that forensic nursing is one of the coolest specialties of any nurse. Really neat that patients show up to the emergency department. They tell the triage nurse, I've been hurt, somebody's hurt me, whatever. They're first checked out medically, and then they're offered to see the forensic nurse. The forensic nurse is typically on call and they're paged. They need to be at the hospital within 45 minutes. They meet with the patient privately, and it is one-on-one, unlimited time care. And it is all directed by the patient. So they can consent to having a full forensic exam and reporting to police and whatnot. That's great. Or they can just say, listen, I just want to make sure I'm okay. I really don't want to involve police. I don't want the forensic exam. And the nurse will do a checkup, provide them some medications for prophylaxis, and bada bing. So this was amazing. I mean, patients always would say, like, what an amazing nurse. And we would get hugs afterwards. And then we would go to do discharge. And the moral distress that was created by having to discharge these patients into medical system that would not accommodate them, wouldn't understand their stories, didn't have time for them, didn't understand brain injury, didn't understand the trauma associated with violence, was really morally distressing. And we knew that patients were not getting follow-up medical care. We also knew from research that people who don't get follow-up medical care are at risk of chronic diseases and chronic illnesses. They're at risk for gynecological conditions and sexually transmitted infections. They're at risk for untreated concussions. They are at risk for stroke from an unrecognized non-fatal strangulation. Say carotid artery dissection. We knew that they're at risk of mental health conditions or mental health relapse, substance use relapses, or triggers for using substances. There was so much stuff that we knew they're at risk for. So it was really morally distressing. And I was one of these forensic nurses. And I remember just feeling really awkward, like, so good luck to you, goodbye, and knowing that I was putting them into this black hole as soon as they left the emergency department after this amazing care that we were able to give them. So let's introduce 2015 Embrace Clinic. The government of British Columbia provided some money for health authorities to hire nurse practitioners. And the coordinator of the forensic team at the time applied and was approved for 2 nurse practitioners to be assigned to the forensic nursing service. And then I was one of those first 2, and then we were tasked with trying to figure out how we were going to do this work. And I'll tell you now that there's this beautiful vision. When I got hired, I thought this was my dream job. It still is my dream job, but it was a job I walked into that wasn't developed, and we didn't really know how to make the vision happen. The vision was provide follow-up care to the people who've been seen at the forensic nursing service, find the people who don't go for forensic nursing care, but still want or need medical care and follow-up, and see the people who it's been more than about 5 to 7 days since their incident. Now, violence is not as easy as, say, diabetes clinic. It's not like we could put a sign up and say, hi, come to the rape clinic. Not something people are going to walk through, unlike, say, diabetes. And it's also hard to find survivors of violence and figure out what we're going to do with them. So first of all, I guess we had to figure out what are we going to offer and what level of care, and then how do we find these people? So, what type of medical care do patients need after forensic exam was our first question, and the first thing we had to sleuth out. And so we came up with a very long list, and I'll tell you this is not exhaustive by any means, but a lot of survivors of sexual assault are really concerned about STIs and HIV. Unfortunately, during a forensic exam, we can do baseline STI screening, but it's really not accurate because being exposed to something and then 24 hours later being tested is not accurate, like a pregnancy test. You can become pregnant one day, but tomorrow your pregnancy test isn't going to be positive yet. It's going to take a few weeks. Same with STI screening. And so, we have a lot of follow-up around, okay, let's test you at the appropriate intervals and make sure we initiate treatment and prophylaxis as we need to. We do a lot of pregnancy testing, of course, and our clinic offers medical termination of pregnancy for any woman in our community who needs it, but there is definitely a handful who have experienced sexualized violence and are now pregnant because of that. We offer unbiased options and work with the local prenatal clinic that works with women who are in high-risk situations, including substance using, but also in domestic violence situations. So if they want to carry through with their pregnancy, we have a great team that we can connect with. We do a lot of safety planning and connect with our local victim service organizations to partner with them to ensure safety planning. I have every day a conversation about strangulation and safety with a domestic violence partner and the things that we need to think about. We assess, manage genital, anal discomfort, injury, pain. We assess strangulation and head injury. We often are the first one diagnosing it, despite continuing to try to pressure my emergency department colleagues. They don't seem to quite grasp that concussions happen in violence, not just in sports and car accidents. And so, typically, as we all know, I'm probably preaching to the choir here, a football player shows up to the emergency department and they say, hey, I got smacked in the head. I was unconscious for 3 seconds. That's what coach told me. And they get a full head and neck workup. They get a CT scan, not really needed, but hey, let's do it anyways. And they get a referral for the local concussion clinic. They get a note for some time off school and work. Awesome. Our domestic violence survivors come in with this big gash on their head or a big lump, black eye, for example, broken nose, and they say, yeah, my partner beat me up. And they are given a once-over and a pamphlet for counseling and told to go see the forensic nurse. And so they're undiagnosed, which can have implications in the legal system. So maybe, oh, it wasn't that serious. Didn't have a head injury really, right? No, nothing on your emergency department record about being hit in the head or having a concussion. They thought you were good enough. And of course, we've often made women, especially survivors of violence, out to be that this is a PTSD issue. And I'm not saying it's not, but we've ignored the physical stuff for so long that every time someone discloses violence, we think, oh my God, counseling, and send them to counseling. And we forget to do the medical part and the physical assessment and treatment. So we really wanted to focus on that. And so often I'm the first person diagnosing somebody with the brain injury and then coming up with a treatment plan. We do some suture removal, some minor wound care. We refer them for counseling. Pick your jaw up off the floor. We do not have counseling or social worker connected with our program. And so that's something we've been advocating for since the inception of Embrace Clinic, but especially more strongly in the last 3 to 5 years. We do a lot of sleep treatment. There's a lot of sleep issues after trauma, regardless of head injury or not. And then, of course, those are compounded when we have head injuries. We help a lot with emotional well-being and mental health supports. We help people access substance use services if that's something that they are ready for. We do a lot of contraception as well. It's often a time where they realize, maybe I need to be on some, or to control my own reproductive health. If this is going to happen to me, I need that as well. And then the other thing that we discovered was patients really want to know their test results. And that's the question I get asked probably most often by patients is, what are my test results? Now, first of all, they want to know if we found DNA. Forensic nurses, and I'm quite sure it's the same in the United States and other parts of the world, are simply the collectors of potential evidence. And here are the words I say, potential evidence. We don't know if it's evidence or not. We're just collecting what we think might be valuable in a police investigation. So if we collect a swab of the genitals, we don't know if there's DNA there. We don't know if there's semen or sperm. We're just collecting stuff based on the story that's been told to us. We start with believing everybody, and that guides our forensic exam. And so patients really want to know the results of their forensic exam. All of those things are actually passed to police. So they're only processed and looked at least here in British Columbia and most of Canada. Forensic kits are only looked at when there's a police report made and based on the investigation. And so I do a lot of re-explaining that there are no results of your forensic exam because the police need to process that. And if they have not reported, but we will store their forensic specimens up to 1 year, I'll say they're just in storage. They're in safe lockdown storage, ready to be handed to the police. But in the hospital, we don't actually analyze or process forensic specimens. But what we do is medical stuff. And so in our program, when the forensic nurses collect any medical specimens, typically they are sexually transmitted infection and HIV testing. It's actually done under our clinic's name, so Embrace Clinic, and I get all the results. And so anything that comes out positive would be me addressing it. So how do patients find out their medical test results after the forensic exam? Well, we call them. We offer to let them know, yes, everything's fine. Also have a conversation about, we need to retest you in the appropriate window periods and intervals based on the incident and what we need to test for. And who's responsible for calling these patients? So in a lot of programs where they don't have a follow-up specialty service like this, it would be an emerge department doc, probably maybe a nurse even, who's just calling being like, hey, so you have chlamydia. They may not know why they were being seen in the first place or even how to interpret some of those specimens. So if the chlamydia is positive, it doesn't necessarily mean it was from the perpetrator. But often our survivors are misled to thinking, oh, that perpetrator gave me chlamydia, not my regular partner. And then unfortunately, they're treated once, but then their partner and thing isn't treated as well. How do we know the safest way to contact people? So that was one of our biggest challenges, is how do we make sure that it's safe to contact these people? What is the best phone number? Should I use a password or should I use a different name? And we came up with a consent to contact form that when patients are discharged by our forensic nurses, they give us their phone number, they tell us whether we can text them and phone them, whether we can email them, if there's a safer number, like their best friend is safer to contact them through. And we follow that very carefully, and we are very careful about confidentiality and being as private as possible. We don't give out test results over a text message, for example, but we can contact people and say, hey, can you give me a call, or what would be a good time for me to call you? Or can you come in and we can have a chat, which is a lot easier. A lot of programs don't have text messaging with patients, at least not here in Canada. We're way behind in our technology in our healthcare system, but our clinic phone is actually a cell phone, and so we can text people as well as phone them and email them. So think about when you come to the emergency department for a heart attack. And they say, you know what, you had this little mini heart attack or a little mini stroke or something. And they work you up and they say, you know what, I'm going to refer you to the cardiac clinic and you're going to get follow-up there. I'm going to refer you to the stroke clinic and you're going to get your follow-up done there by the specialty team. If you come in for suicidal ideation, you get a referral to psychiatry for follow-up. When you're seen for a pregnancy, you get follow-up with public health or a prenatal clinic afterwards, right? Even football players with a concussion get a referral to the concussion clinic. Our patients don't have anything. So why not have a specialty rapid access provider or service that supports similar care? And that's what Embrace Clinic is. Embrace Clinic really is the rapid access, urgent follow-up clinic for people who've experienced recent violence. So for too long, like I said, violence has been treated as a mental and emotional trauma, and the physical trauma has been undermanaged. And I don't want to discount that our survivors of violence have mental, emotional, spiritual traumas. But we also need to remember to treat the physical aspect of that as well, if we have any hope of getting better and being able to manage some of that mental and emotional trauma as well. We also see that violence is often not invited to the table, specifically healthcare. So I love being here today. Thank you for having healthcare here. There's many advocacy tables, research tables, political tables that are talking about violence. And one of the things that we recognize here is that healthcare is often absent at these tables, and that we're forgetting about the healthcare component of violence because we're looking at things like shelters, we're looking at counseling, we're looking at victim service support, we're looking at children and protection and safety of children, we're looking at police and navigating court and legal and justice systems. It's like healthcare is the aside. Oh, right, just go to your family doctor. And so we see that a lot where we are not invited to the tables, and that I think is a problem because this is a multi-sectoral issue. And I believe that survivors of violence deserve good, high quality health care, just like someone surviving a heart attack or someone experiencing suicidal ideation. They deserve specialty services. And I think people who've survived violence also deserve those specialty medical and healthcare services, as well as the mental health and support services and the legal services and the child protection services. Whew. So here is Sheila Early. We had our 30th anniversary a couple years ago, so in 2022, celebrating 30 years of forensic nursing service at Surrey Memorial Hospital. And she really had the vision to create where we are now. So obviously it starts small. She's got a lot of newspaper articles written about her, and she really is Canada's pioneer in forensic nursing. So the vision for Embrace Clinic became to provide follow-up medical care for people who've been seen by our forensic nursing service, to provide medical care to people who'd experienced violence, and to be accessible and trauma-informed. Okay, so now we turn a vision into reality, and we had to believe in unicorns. And I'll tell you, the vision sounds amazing. And then we ask the question, what does my day-to-day look like? Like, it sounds wonderful to try to offer all these things, but where do I find these people? How do they get to me? How do I get to them? How far do I take them? How long do I care for them? Like the operationalization of this service was really challenging. How do you safely contact people? How do you find the people who don't go for care? How do you find those who it's been more than the forensic exam time? How long do I keep them for? How many times do I see them? What types of service can I offer and what can I not offer? And that was what we had to work out. And that was our challenge. So Safety, confidentiality, and trauma-informed practice. How do you safely contact people? Like I said, we have a referral or a consent to contact, and that allows us to safely contact people. Now, we do not need a referral for patients to access our clinic. They absolutely can call and self-refer. We try to be as open door as possible. But when you think about creating a service, think about the safety aspect of contacting people. So if they're going to be referred by the emergency department or they're going to be referred to by a counselor or a family doctor, we need to know that the patient is both consenting to having this follow-up specialty care, but also what is the safest way to contact them. Safety is very key in our population. What does our phone number show up on our caller ID? So we've made it so that it says Fraser Health, which could be anything. Could be about vaccinations, could be about, screening mammograms, whatever. We needed multiple ways to contact people. So we very quickly decided to make our clinic phone a cell phone so we could text, email, and phone people. How will the medical chart be created? Okay. So in our service, we keep forensic records separate from the medical chart. So if somebody requests the medical record, all they get is the emergency department visit and information about the medical care provided. All the forensic stuff really is the legal documentation, and it's meant for police investigation. So that is kept separate and is really only released when there is a investigation occurring or something is going to the courts or legal system. In my clinic, I have an electronic medical record. And so an electronic medical record means that I'm charting like a regular clinician. So I don't separate my forensic details. So I need to be careful what I document as well. Will police or courts have access to my documentation? And is there a different process for accessing those records? Are the follow-up providers prepared to go to court as well? And so these are things to think about when establishing a follow-up service to ensure that the providers are ready and prepared. It's not as simple as just, yeah, sure, I'll do some medical care. There are some pieces to think about. Here's the top half of our consent to contact. So as you can see, we've written here, you've got options for 3 different phone numbers to let us know if voicemail or text is okay. There's lots of blank space to fill in. And often the patient or the forensic nurse will fill it in and write mom's number or best friend Sue. How do we want to be contacted first? What is their preference for us to initiate contact? Phone call, text, email? Do we need an interpreter? Are there any contact instructions like don't call me between this time and this time, or use the code name Sally when you call? And so that's how we establish that if somebody's not self-referring and they're being referred by someone else, or the forensic nurse is saying, hey, we can follow up with you. We get their information this way. They also can say, no, I don't want follow-up care, and that's fine. And then we inform them that if there are any medical test results that need follow-up, they'll be getting a call from the emergency department based on what's connected with their care card number or their health card number. And there will probably be very little confidentiality or sensitivity, trauma-informed discussion. I think it's about 85% of our patients consent to being followed up after a forensic exam. And then we get a little bit of detail on the bottom half of the form. We don't want the forensic record. We don't want all the details, but there's some specific things I like to know, which helps me triage and walk through what we need to think about in terms of this issue. So referral, we work really closely with an organization called the Surrey Women's Center, who's a community-based victim service organization. So if the patient says, yeah, I'm happy to be referred to them, they'll check that off and we fax this form to them as well. And then they work to contact the patients as well. I like to know the date of when things happened. Was this a medical only or was a forensic exam done, and was it reported or not? What types of violence occurred? And some of the basic things. Was strangulation involved? Was head trauma involved? Did they lose consciousness? That gives me an idea of whether we need to physically see somebody or maybe we can just do a phone visit. So how do we find the people who don't go for forensic care? And how do you find those who it's been more than 5 to 7 days? How do we advertise? as a clinician, advertising is not my forte, so networking was really key. Again, who's got time for that? We did meet with a lot of victim service organizations, and we made connections with mostly victim services, some police departments, and said, "Hey, we're open and we're here." But really, a lot of people don't know that we exist. Embrace Clinic was named specifically because it's not a targeted name, but then it also means that people don't know what we do. So it's that catch 22 as well. So the first thing we did was we partnered with multiple organizations, which was great for collaboration. But we were there like 1 or 2 days. I was there every Tuesday and Wednesday, and I was at this place every Friday, and I was at that place on Thursdays. It was really hard for patients to find us. We were really at the mercy of the operations of other organizations. So if there was like a training day and they shut down for the day, I had to figure out where I was going to work that day or see patients. We did a bit of outreach and mobile response. So we trialed going to transition homes and shelters, but often I would sit there and see nobody because they didn't think they needed medical care. And what they were looking for is counseling, for example. So they don't really want you there unless they need you there. And so it didn't really work out very well as well. There was also a lot of schluffing of supplies. I did a lot of work out of the trunk of my car, and we were very mobile. So the our clerk, so we have a unit clerk, and she would answer the phone in the hospital and sit in the forensic office in the hospital, and I wouldn't see her for weeks at a time because we would do everything virtually and remotely. And this was before all the virtual care stuff came out. This was 2015, well before our COVID changed the way that we work in medical care. So then COVID happened, and suddenly we were locked out of all these community-based organizations. And this was awful for us, but also real silver lining. So suddenly our community partners shut their doors. They were seeing people only virtually or by phone. And we said, well, we still need to see people. We still need to touch people. So they set up a temporary space in a boardroom for us. And this is a picture here of like trying to make a private exam space in a boardroom. It was totally awkward. It had its own bathroom, but other than that, it was a bizarre space. And we just sort of pieced it together. We took what we could, we made it work. We did a lot more phone follow-ups than ever, but we were saying, we really need our own space. I think this tells us we need our own space. So there's the exam portion of the boardroom. Okay, so then they said, "Oh, we've got this basement, which is where I am now, in this old building across the street from the hospital. Are you guys interested in that?" Well, I said, "Okay, why not?" Right? So Embrace Clinic started. There's me in my mask when they put up the sign for Embrace Clinic on the sidewalk. And this here is a picture of them putting in a washroom. So interestingly, this was a space that had 4 office rooms up front. It had been previously like a housekeeping office or something. And we said, okay, well, the carpets have to come out, first of all. The walls were peach pink with like wallpaper. Nobody had been in there forever, but there was no bathroom. And we said, we really kind of need a bathroom if we're going to see patients here. So they dug up the floor and they put in a bathroom. Our wonderful director at the time also said, "Do you guys want a shower too?" So we put in a shower. So we have a bathroom now that has a shower in it, which was pretty cool, but it was a huge advocacy thing to just get that washroom established. It meant we lost one of 4 exam rooms. So we have 3 exam rooms now. So this was probably within the first week of opening Embrace Clinic. We had all brand new furniture we got as a donation from our hospital foundation, and then Armstrong Flooring donated the floor. That was, like I said, it was all old carpet, so they put down flooring for us. We were able to purchase one more exam table. All of our exam tables, in taking things like disability into account, they lower almost to the floor, and then they can raise really high up for my back. And so we really wanted that style of exam table there. So you can see we set up our exam rooms. They look really nice. Here it is in the background, being used for a couple of years now. I put some stickers on the wall. We have an office where the two coordinators of our forensic nursing service sit. This is Tara and Lorena, and they coordinate our acute response in the emergency department across the street. It's great to have them here because we can rub shoulders and consult and work on a lot of projects together. And there's our front door. We often will find vulnerable people sleeping at our front door in the morning. We offer them a coffee and encourage them to move along before our patients come. We've had a few overdoses here as well. We are on a very busy corner with a lot of vulnerable people around, and so we do respond to car accidents and sometimes knife fights and other fun things that happen outside our clinic door. So where we are today, we are still in the same clinic space. We're in one physical location, which has made it a lot easier for people to find us, to know who we are, where to go. We offer phone appointments, and then we network around our region, often with other nurse practitioners, to offer a physical exam when needed. So these nurse practitioners don't take on the patient as their regular person, but they're willing to sort of be my hands when patients can't come to me in Surrey. If they're in another city and can't get here, I'll often connect with a nurse practitioner in their community and say, hey, could you just check this person's ear? They're complaining a lot about their ear, or do something real quick, and then I will continue their care. I opened a strangulation clinic in September of 2022 after taking the Strangulation Prevention Institute's advanced training and recognizing that we really needed to name this issue. So just like concussion, you go to the concussion clinic. Diabetes, you go to the diabetes clinic. Strangulation, you go to the strangulation clinic. There's really nothing unique or different about the strangulation clinic of what we always did, which was assess strangulation and head injuries. We just named it. So we named it as part of Embrace Clinic. So we have a strangulation clinic within Embrace Clinic, mostly for referrals. So for physicians and NPs and victim service workers and police, this is where you send people who've been strangled. And that has worked out really well in that way. And there's been a little bit of media about that clinic as well. Just want to check in, Carrie, what time do we end at here? Is it 8?
Sorry, I'm doing the conversion in my head. Yes, 8:15.
Oh, okay, good.
Time for questions after. Yeah.
Perfect. So if we've got time, I'll play you our little media clip
Perfect.
from the strangulation clinic, but the link is also in my slides. The number of patients we've been seeing, especially since we moved into our own place in 2021, has doubled and increased like crazy. We're also better able to support the forensic nursing team across the street. While at this point in time in our organization, nurse practitioners cannot act as medical directors, we essentially are the medical directors for the forensic nursing service. And the nurses know that they can contact us when we're here and ask for help. I can go over and help with an exam if they need, or just ask for advice on what should I do, or maybe this patient's better to come over to you guys than to be seen in the emergency department. So there's lots of collaboration back and forth. In 2022, I guess, we got a Pacific Assistance dog, Levi, who again is fast asleep behind me, which is where he loves to be. But this is actual real patients who gave permission to take a picture. He has gone to the hospital to sit with patients. He is in our clinic room providing just support. His job is to be petted and loved on and to bring the anxiety down. And so we have really loved introducing Levi into the clinic. He also provides a lot of staff support. Sometimes after a really hard day, the nurse will come over and just sort of hug and chill with Levi. And we've been asked to bring him over to the emergency department after some hard stuff has happened, and he'll just sort of wander through, and the EMT teams will give him hugs and pets, and everybody likes that all around. As Carrie had mentioned in my bio, I was actually attending a pink concussions seminar one day, and I think it was a bit of an open forum town hall. And I said, hey, any researchers out there? I think I have good data. I'm not an academic. And I think I got 7 people who responded to me. And one of them was Karen Mason and Paul Van Donkler from SOAR, who I think you may be hearing more about them shortly. And Paul works with UBC, and we connected around, let's just look at some data. So we have forensic records. Every patient who's seen by a forensic nurse has a forensic record created. It's on paper though. But the data is really good because they can't really leave anything blank. These are legal records that might end up in court and in a police investigation. And so they're very thorough and they're very specific, but they're all on paper. And so we need data entry in order to look at them. But I said, we have program stats and we have these rich forensic records. So we collaborated together to look at characterizing brain injury in the patients we saw. A lot of data entry had to occur for some of that. And then we linked again with the Wellington lab to look at biomarkers for brain injury, specifically from intimate partner violence. And at Embrace Clinic, we recruit the participants. So when I see somebody who's experienced any form of violence that they can recall, so not drug-facilitated sex assaults, for example, but any form of violence, and they're interested in participating, they agree to let me draw 2 tubes of blood, and we do it at the end of our medical visit to avoid any sense of coercion. And we give them a gift card in return. And this is my colleague, Jen. She's the second nurse practitioner at our clinic, and she is aliquoting some blood tubes after they've been centrifuged. Then we put them in the freezer, and the research team from UBC comes and picks them up every couple weeks. And hopefully we'll begin analyzing in the short term, but I think we've gone through about a year of collection. We've got about 100 participants at this point in time. We also have a lot of space where we invite other organizations like victim services or police. They can do interviews here or have conversations. We have a couple of other spaces people can work internal and external. And like I said before, we're really working on a social worker. I think that was the part we missed at the very beginning, in that we hired 2 nurse practitioners to do Embrace Clinic. We forgot that we needed the social worker. And unfortunately, the funding just isn't there and wasn't there. And so we are really desperate for social worker services within our clinic. And so Jen and I end up doing a lot of social work stuff, which is challenging because we're not social workers. So I'm walking through a day at Embrace. So usually at 8 a.m., not 7 a.m., I arrive and I check to make sure the building hasn't flooded. Our building is in a basement and it loves to flood. We sandbag outside and kind of joke that we should add advanced flood management to our job postings. But assuming we haven't flooded, we connect with our team. So the 2 forensic nurse coordinators, the unit clerk, and the 2 NPs. We have a little playtime with Levi. We sort of just go over what's happened in the last day or so or over the weekend. Around 9 a.m., I'm checking test results, any referrals that have come in, any follow-ups that I need to do for the day, and I make myself a list of my, phone calls that I need to do. I try to make some patient phone calls, often with test results and things. Between 10 and 12 is patient appointments in person or by phone. Patients do fill out an intake form on their first visit. They're welcomed into the clinic room alone always as a policy. So if they bring a support person with them, we say just 2 minutes alone first, and then then we can invite you in. It's amazing how many times survivors will say, no, they don't need to come in after I have a minute alone with them. I say, do you want to invite your person in? And probably at least 60 or 70% are like, no, we're good. And that's fine. So we try really hard to make sure people are well supported. They're always welcome to bring their support person in, but we try to have those 2 minutes of confidential time first. And I also ask always, is there anything that you don't want me to talk about in front of this person? We give an intro to ourselves in the clinic. We ask if they want anyone else in the room for their visit. And typically our visits are between 45 minutes and an hour for a first visit. Follow-up can be anywhere between 15 and 30 minutes, depending on the situation. In the last couple of years, we've made it a priority to have a team lunch. I used to eat my lunch in front of the computer while checking my emails or answering phones and things. We've made it a priority for our own mental health and well-being to avoid our vicarious trauma that we have our lunches together. We do a lot of team bonding, and I can't emphasize how important the team is here. We deal with a lot of hard stuff. So we do a lot of casual debriefing. And we've become quite close friends as well. So there's a lot of trust developed. From 1 to 4, I see more patients, do meetings, consultations, education. Hopefully around 4:30, I'm packing up if I'm lucky, and I head home, maybe with Levi. Levi also goes home with Jen half the time as well. So an appointment with an NP at our clinic is they're welcomed. We discuss confidentiality and limits to the confidentiality. We do a quick review of an intake form, which really just asks medical conditions, medications, surgeries, and allergies. That's just baseline medical information that I just need. And then we review the reason for their visit. I always, as well as focusing on their physical needs, I always ask about safety and their support support systems, both informal and formal, what their current physical signs and symptoms are, what is their emotional and mental well-being right now, what is their sleep like, and I go over their hospital visit if that's where they've been. We review test results, imaging, we develop a treatment plan. I always assess their current symptoms. We do a focused physical exam, often head, neck, neurological system, or if it's a sexual assault and they're worried about that, we can do a pelvic exam, or we can do less invasive screening with a urine and a blood test. I document visible injuries, but don't do full forensic exams here. So I don't have the capacity to maintain a chain of custody. So we don't collect swabs or specimens that we would keep and then hand over, but I can document injuries. Both myself and the other nurse practitioner, Jen, were forensic nurses before we were nurse practitioners. So we come with that training and background as well. We do treatment and care. We book follow-up appointment. Usually the follow-up appointments are about a week later, often by phone, unless the patient wants to come back in and see us. We, absolutely welcome all of that as well. So that's a basic appointment with us at our clinic. How do we try to be trauma-informed? I mean, trauma-informed is different for every person, and so we try to be as broad and culturally sensitive as possible. That being said, our number one culture here in Surrey is South Asian, and so that's where a lot of learning has had to come in, was how we manage and work with our South Asian population. But I think in terms of cultural sensitivity, we try to be open as much as possible and welcoming to everybody. So appointments are offered both in person or by phone. We don't do any like video visits at this point in time. We realize it's not always safe. People don't always have access to video conferencing type equipment. So phone call is fine. They can contact our clinic, phone, text, or email. They do not need identification or a care card or a health care card to see us. Because we are nurse practitioners, we're paid a salary. So we don't work on a fee-for-service system like family doctors do in our system. So I get paid a paycheck every 2 weeks. It's the same paycheck whether I see 3 patients or 300 patients. And so we don't require that. However, to order certain lab tests and imaging and things, those are paid for in Canada by their care card. So they either have to private pay, or I'm not able to order that for free for them. So it's a bit of a hand tied behind your back, but we can see undocumented people or people who don't want to provide their identification. Our intake form asks for qualitative information, so we don't ask if you're male or female, we ask gender, and we just say, you identify your gender, you determine your own pronouns, and we will do our best to accommodate those. That being said, in an electronic medical record and a healthcare card, often those are not changed to their preferred gender or pronouns, and we do our best to try to make notes so that other providers accessing might use their appropriate pronouns. It's not always perfect, but we try. Our washroom is gender neutral. The one we advocated for is just a washroom, and it says all genders welcome on it. People are always seen alone for a first few minutes before inviting a support person in. We have a very small little waiting room, a very casual team, and Levi being here, if people are afraid of dogs and don't want him, he goes into another room and he has a bed in the other room. Easy peasy. But a lot of people actually will knock on our door and say, "Is Levi there?" And they just come in for a quick hug and a pet with the dog. We have clinic rooms with curtains that are between the exam table and the door. You can see that right there. The door is actually in front of me. You can't see, but behind me there is a exam room curtain that divides the exam table with the rest of the room. Like I said, we give lots of time for appointments. We don't rush through them. We try to have pictures and art on the wall that is nondescript. So we don't have moms and babies and happy looking families and anything that might be seen as potentially offensive or triggering. I even have on my ceiling, I don't know if you can see it, I have cloud paper there. So when you're lying down on the exam table, you can look up and hopefully there's clouds instead of just ceiling tiles. We are very careful about our language as best as possible. Language like, I don't call the exam table a bed. Bed is where sexual assault happens. I call it an exam table. My colleague calls it a bench. Some people call it a stretcher, more medicalized. I talk about people's bodies as healthy and normal, not as nice or good or fine. I don't call people sweetheart. We can often have some good humor in things, but we try to be very careful around triggering words and triggering languages. We also have the ability to dim the lights in our clinic room and use like a lamp. I do that often with people who have a head injury. We also have 2 free parking spots, which is rare in a hospital environment. So if people are coming by car, they just register their license plate with us and they can park for free during their clinic appointment. This is our team. I would be remiss to pretend that it's all me. I have probably been around the longest, but our team here is amazing, and it's the reason I've been in this role for 10 years. I love the patients, but I also love my team, and I would never want to do this work without these people. They're all passionate, dedicated, and really into making things better in our world. So to just wrap things up, the challenges that we continue to face is that violence is still not routinely seen as a healthcare issue. Systems are not supportive or designated to assist people in fleeing violence. We know this. The roadblocks that women have to overcome in order to flee is so many. We have limited access to social work. In fact, no social worker that's dedicated to our clinic. We're a very small program run by a very small team, which has a risk for burnout. So we've tried to do things like have lunches together. We're not a money-making or sexy issue, so we get a lot less attention and resources than other programs. They're currently across the street building a brand new renal building, and so people with kidney disorders and renal issues get a whole brand new building, and we're still like, hi, we're flooding today. So, violence just doesn't get the attention the same way. NPs and nurses are often not acknowledged as experts, and yet I would argue that forensic nurses are some of the most amazing experts in the world of violence, but we're not often looked at as experts, especially in courts, and often not paid to come to court. Take your jaw off the floor again. We're all working in fragmented systems. We have limited access to collaboration. People are overwhelmed by the number of calls they get. Like when a survivor gets calls, they get calls from police, they get calls from us, they get calls from victim services, from child safety. It's overwhelming, and I would love to have one center. Our no-show rate is very high. That's the population we work with. We do not charge fees for no-shows. There are times when you've missed so many appointments that we just say, you know what, call us on the day you want to be seen and we'll see if we can squeeze you in. And we try to accommodate that. And of course, there's always geographical limitations and transportation limitations in accessing a service that's in one city when you've got a large region. So the vision for our future of Embrace is a family justice center model. We would love to have forensic care on site. We would love to have police and Crown and counselors and victim services and childcare workers and Indigenous health navigators all sitting together. So there's one phone call, one place to follow up, and we don't have to fragment our systems, and we can case conference together. That is it for me. Any questions or comments? And I'm happy if you want to contact me one-on-one, I'm happy to follow up as well, because I know we're on a timeline.
Hannah, that was fantastic. I learned so much. My head is kind of spinning right now, not gonna lie. We do have a couple or a few questions in the Q&A. So I'm gonna ask you a couple of them, and if we don't get to all of them, maybe you can address some of them after this.
100%.
So how many patients do you typically see per day, per week?
With the high no-show rate. So for example, today I have a fully booked clinic. So I have 3 patients this morning and I have 5 patients this afternoon. So it's 8 to 10 is a fully booked day per and nurse practitioner. I will tell you probably 50% of them will show. So I expect to probably see 5 to 7 patients today. I also do a little bit of extra work to keep myself mentally well. I do a bit of episodic women's health. So I do some IUDs and contraceptive implants, and we do some STI screening for high-risk populations. So I don't see all violence all day. I think I have 4 violence patients today scheduled. One of them is definitely a tentative. So yeah, we have to be pretty relaxed around if people are going to show up or not.
Thank you. Okay, so this question from Molly says, thank you so much for this important discussion. I work in Vancouver DTES as a sexual assault response coordinator and can say we have extremely limited services in our community clinics. We don't have what you are describing with the Embrace Clinic and don't have any accessible services for women experiencing brain injuries who are unhoused and using drugs. What do you suggest as strategies for supporting folks in these settings when we don't have these options available?
Nurse practitioners. Nurse practitioners are one of your key people for a couple of reasons, in that they don't work on fee-for-service models. And so things like vulnerable populations are more easily serviced because we don't our livelihood doesn't depend on people showing up, but also they come from that nursing model and has the skill set to manage almost everything that needs to be managed in this population. And so, nurse practitioners, I think, would be a place to start. Connecting with some NPs and or forensic nurses to determine if they could accommodate this population just in their practice. So rather than creating its whole Embrace Clinic alone, sometimes people are willing to say, I can see people if they're referred by you or your organization. Just let's develop a specific pathway, and then I will accommodate these people. I may not be able to attach them for long-term care, but I can at least accommodate them for their temporary specialty need around their most recent violence. The challenge that we faced early on was we were being pressured to actually become the primary care provider of our patients. And we very quickly said, whoa, as soon as we become the primary healthcare provider and we attach these patients, we're full. We're full in a year and we'll never see anybody new. So that we really developed ourselves as a specialty clinic. We are episodic care, but there are patients I've been seeing for 9 years. And I'm probably the only healthcare they get, but they don't name me as their healthcare provider, but I'm probably the only healthcare they get. Possibly linking with places like Wish in downtown East Side is a good place to start, and determining if any of the nurse practitioners or clinicians there are interested in getting more training on strangulation, head injury, violence care, and they might be a place to do that. Really, you're going to need to watch out for grants and watch out for funding opportunities, especially as things become sort of sexy. So when Me Too came out, the government was like, how do we respond to this? And that's where you got to grab the funding. At that point in time, when the topic area becomes the sexy topic in politics, that's where you got to be ready with a proposal and grab that there.
Awesome. Well, with that, thank you so much. That was a fantastic talk. There are some questions in the Q&A if you don't mind. Again, we're so grateful for you giving this talk, and now we will move into our other sessions. This morning, I realized that I didn't give a specific shout out to 2 people that I needed to. The first is Ella Carlson, and the second is Divya Jane. You probably got many emails. They really helped with organizing all of this and making sure that all of you got the info. And also, have you been noticing in the alt text in the chat, they've been providing alt text for the speakers. So again, thank you to them.